everyone. Good day, good morning, good afternoon, good evening. Thank you so much for attending this session and thank you for making this event possible. We trust that the session from the previous chapters have been of your interest and have contributed meaningfully to your professional development. My name is Grace Wange. I'm an associate professor in public health from Monash University, Indonesia, and part of ISoP Indonesia chapter. I'm delighted to host this year's session for the South Asia, Indonesia, and China region. On behalf of the International Society of Pharmacovigilance, we are very pleased to welcome all of you to the 6th edition of the ISoP Patient Safety Day event that will be held on September 18 and 19. Ladies and gentlemen, as you know, the World Health Organization has designated every year on September 17 as the World Patient Safety Day to enhance public engagement in health safety and to promote global action aimed at preventing and reducing harm associated with healthcare delivery. This year, the theme that is chosen is Safe Care for Every Newborn and Every Child, under the slogan, Patient Safety from the Start, to highlight the particular vulnerability of this age group to risk and harm resulting from unsafe care. In ISoP, we reaffirms this objective of WHO Global Patient Safety Challenge and calls on stakeholders and also health professionals to prioritize and take early action in critical areas associated with significant harm in pediatric and neonatal patients due to unsafe medication practices. These areas include high-risk medications, look-alike, sound-alike, or LASA drugs, dose conversion, care transitions, polypharmacy, adverse drug reactions, and other major disruption in the delivery of healthcare services. To start the event, we would like to listen first to our president, Dr. Angela Caro, that will address a few words to all of you. Please listen to her video.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Thank you, Angela. Muchas gracias. So, ladies and gentlemen, as Angela said, we encourage you to contribute to the broader dialogue by sharing also your reflection of this webinar and also probably your experiences regarding this event through social media with the hashtag ISOPPSD 2025, World Patient Safety Day 2025, WPSD 2025, and also tag us at ISoP Online with another tag like pediatric safety, child safe care, and no harm from birth. So without further ado, tonight, or in my place, it's during the nighttime, I have two excellent speakers. Let me introduce the first one. The first speaker is Professor in Anesthesiology, Professor Sweta Viraj Salgaonkar. Hello, Sweta.
Hello.
Are you there? Hello.
Yeah. Yes.
Okay. And Sweta will tell us about pediatric anesthesia, how we can navigate safety. Sweta is a professor in anesthesiology and also pain consultant at SET, GSMC, and PAMH from Mumbai. She's a facilitator for FAST, Vital Anesthesia Simulation Training, and a fellow of Indian Academy of Pain Management, and also past associate editor in Journal of Postgraduate Medicine, Indian Journal of Pain. Her area of interest including difficult airway, pain management and awareness, and non-technical skill for anesthesiologists. So I will invite you during Sweta's presentation to participate actively by posting probably your questions and comments in the chat box. And later during the Q&A session, which is will be held after the second speaker, we will respond to some of your questions. Or also feel free if you want to post your question directly to Sweta. So Sweta, without further ado, please, the time is yours.
Yes. Yes. Thank you so much for your kind introduction, and I'll share the presentation. Yes. Yeah, so greetings to all from GS Medical College and KEM Hospital. This twin institute has entered its centenary year, and I'm so privileged to be associated with this for 3 decades. I congratulate ISoP for organizing this scientific webinar on such an extremely important topic of patient safety in pediatric population. And I thank the organizers for giving me this opportunity to share my views on how we navigate pediatric patients safely during the conduct of anesthesia. So the roadmap is going to be, why are we discussing this topic? What are the anatomical and physiological differences amongst between the children and the adults? Pharmacokinetics and pharmacodynamics, how are they different? What expert technical skills and non-technical skills which are required? The human factors involved in conduct of safe anesthesia, off-label use of drugs, and summary at the end. So we need to have a safe patient at the end of the surgery and anesthesia. So coming to why are we discussing this topic? Why this topic is chosen by ISoP? Well, for anesthesia in children, does it children do really mean they are miniature adults? Well, they constitute a diverse heterogeneous population from preterm neonates to post-pubertal adolescents, and they are in different stages of development. Pharmacokinetics, dynamics are all different. Drug interactions also are different. There is polypharmacy involved in anesthesia. And many a times, this kids, they are getting exposed to first anesthetic, and they could be associated undiagnosed anomalies, allergies, which may get revealed only under anesthesia, and that's where there could be increased incidences of unanticipated issues. There is absent patient cooperation, as we understand, and small babies, big impacts means small periods of desaturation can cause major impact on neuronal functions, which can adversely affect immediate and long-term patient outcome. And we have paucity of clinical trials in children, and most of the drugs techniques that we use are extrapolation from the adult clinical research and trials. So that's the reason it's such an important thing that we are talking about. So for anesthesiologists, the airway management is the most crucial event during the entire anesthesia process. And what are the unique features of airway anatomy in pediatric patients, especially the young children? There is large occiput, large tongue, shorter mandible, higher larynx compared to adults, and all these can make these children prone to upper airway obstruction. They have small mandibular space, which makes the laryngoscopy very difficult. And epiglottis is U-shaped and floppy. They have subglottic area, which is narrow. That makes intubation difficult, which are very much required for airway control during anesthesia. And how do we mitigate this risk? We put the shoulder under the shoulder blade. We use straight blade of laryngoscope, and we use a smaller size endotracheal tube. What are the unique physiological and functional features that we see in these children? They are obligate nose breathers. They have low functional residual capacity. There is increased workload on diaphragm to maintain the tidal volume. So it gets easily compromised because of any stomach distension that can occur because of crying or mask ventilation. Chest wall is highly compliant and floppy. Respiratory center is sensitive to opioids and chemical stimuli. There is immature blood-brain barrier, and there is higher metabolic rate. All this gives us very low safe apnea time in children, and thus they are prone to desaturations and hypoxia. There is apnea susceptibility, so opioids are to be titrated. There is high oxygen demand. And how do we mitigate this risk? We continue oxygen, the alternate source of oxygen during anesthesia, that is peri-intubation oxygenation is on. There is gentle mask ventilation. The table is always put in the head up, 25-degree head up tilt. Airway gadgets, experts, and plan all are in place before the child is taken up in the OR. Guidelines and cognitive aids are used, and drugs are always titrated. There are unique further features are developing brain and spinal cord and neuronal connections. They are in the developmental stage. That makes the drug responses sometimes unpredictable, and even patient has unique pain experiences. There is dominant parasympathetic system, which makes them prone to bradycardia, where the heart rate of less than 60 is considered as a cardiac arrest in pediatric patients. There is immature organ function, which leads to delayed drug metabolism and excretion. There is developing immune system, immature coagulation cascade, and temperature regulation. All of this make them prone to recurrent infection, hypothermia, and coagulation. So how do we mitigate this risk? By optimal drug doses in regional and neuraxial blocks during conduct of general anesthesia, and even the IV fluid is like a drug, so the dosages have to be calculated very accurately. The parental separation is a very important aspect, and that we do it in a very pleasant way where the child does not cry excessively, which can make him or her prone to respiratory adverse events. So there is always very pleasant parental separation. Normothermia by active warming is always done, surface warming as well as core warming. Coming to pharmacokinetics and dynamics, we understand that children have a very different body composition. They have increased body water content, decreased muscle mass, increased volume of distribution. So the initial doses of the water-soluble drugs required are more, and there is but decreased organ function. So maintenance doses go down. There is low protein binding, so there is increased free fraction of drugs and delayed gastric emptying. So the absorption and peak effects of the orally administered drugs are slower. There is further increased sensitivity to neuromuscular blocking agents due to immature neuromuscular junctions. And this can have the consequences, like we know, because of the genetic susceptibility. There are many patients, pediatric patients, who can have a serious adverse event like malignant hyperthermia following suxamethonium, which is a depolarizing muscle relaxant, or because of the inhalational agents. There is decreased minimal alveolar concentration of inhalational anesthetics. So there is faster wash in and faster wash out. The in and out of anesthesia can happen fast. There is increased requirement of amide local anesthetics for spinal blocks. There is poor response to bronchodilators and prokinetics because of paucity of bronchial smooth muscles. And hyperoxia, that is FiO2 of 100%, especially in premature or neonates, can cause retinopathy in these patients. So there is possibility of under or overdosing in this patient. Now, children who come has some congenital anomalies or syndromes, they present very peculiar problems, like patients who have got muscular dystrophies are prone to cardiac rhythm issues. Those who have vertebral, anorectal, and esophageal anomalies, they have this syndromic faces and maxillofacial issues, so they present with difficult airway, delayed recovery. Patients with hypertrophic obstructive cardiomyopathy or asymptomatic critical AS may face sudden death. Those with right to left shunt, like a tetralogy of Fellow, they are prone to air embolism, so their IV infusions have to be totally air free. Patients who have neonatal jaundice, they have altered drug metabolism and risk of hypoglycemia, convulsions, and the consequences. Childhood anemias are not uncommon, and that can make a patient more prone to post-surgical morbidity. The healing is affected. The critical incidents that commonly occur in pediatric patients during the conduct of anesthesia are the respiratory adverse events, the oxygen desaturations, airway obstruction, laryngospasm, especially because of inadequate depth of anesthesia or post-recovery. Laryngospasm is not an uncommon adverse event that we come across. Bronchospasm, apnea, airway trauma, or airway edema, vocal cord edemas can occur due to multiple intubation attempts. Other common problems, there can be medication errors because of the incorrect dosing, IV excess issues, cardiac arrhythmias, temperature regulation, post-op pain and delirium. Not to forget local anesthetic systemic toxicity, that is last because of any of the intravascular injection of local anesthetic or because of the overdose and the faster absorption. Malignant hyperthermia, we already talked about. So this NAP4 project that was published in 2011, and it was about the major complications that can occur after the airway management, that said that most of the problems were because of the poor management rather than the problems of the technical skills. So, and NAP4 recommended the use of checklists and SOPs. So the subsequent paper that was published in 2012 also said that though we see the problems as failed intubation or extubation related problems or difficult or delayed intubation being the problem, why that failed intubation occurred or why that extubation related problem occurred is probably because we were not prepared adequately. There was a poor assessment, poor planning, closed loop communication probably was the problem. Teamwork and leadership or situational awareness was lost, critical thinking or dynamic decision making was delayed. So these are all the non-technical skills which are also extremely important in the conduct of anesthesia. So to understand non-technical skills, we understand what are human factors. That is how humans interact with the elements of the system, such as equipment, task, culture, and workspace. We understand that healthcare is a very complex system, and this is what we have to understand. The technical skills are very easy to understand, but non-technical skills are very subtle. So the system should be such that, and the training should be such that it should be easy for workers to do the right thing and difficult or impossible for them to do the wrong thing. So wherever we can fill the gap, we must do it. So there should be less reliance on the exceptional personal and team performances to provide safe and high quality patient care. The bottom line is the human factors are key to the safe delivery of the healthcare. What are human errors? Where an act of being wrong in conduct or judgment or ignorant or imprudent deviation from a code of behavior that fails to achieve what should be done. In anesthesia, a large number of errors are unredeemable and may reduce the possibility of an optimal outcome and hamper the patient's safety. Medical errors in anesthesia are associated with high rates of death, brain damage, less than appropriate care, and high cost. So when we talk about patient safety, definitely it cannot be without the talking about the Swiss cheese model or a Parmesan block model. So that is about here, Professor James Reason, he explained the stack of Swiss cheese to explain us the multiple levels of our healthcare system and where the holes represent the aspects of the workload, workflow, training, equipment, communication. And when the holes line up, as in multiple slices of Swiss cheese, a hazard or an error can become an accident. So to give that example, if the child is having the right kidney problem, and if for whatever reason at the registration counter for multiple reasons that if it is noted down as left kidney problem, and if the resident, the surgical resident or the staff nurse in the ward or the anesthesiologist has not checked it, then the holes line up and the patient undergoes a wrong side nephrectomy. And that's a really morbid condition that we are pushing the patient into, that is really compromising the safety of the patient. So that's where he has tried to explain this very well. Other explanation is by Parmesan cheese model about the patient safety. There, every time a substandard practice is followed, an adverse incident may or may not occur immediately, but we shave off a piece from the patient's whole, and that decreases the chance of the optimal patient outcome. Like it is not as gross as we say the wrong side surgery here. If we say there's a prolonged or inadequately treated hypertension, that might be not sufficient to cause a life-threatening injury, but yes, it can cause an acute kidney injury, which may get converted into a chronic kidney disease. So this model represents the clinician's responsibility in routine patient care and importance of minimizing any deficiency in our day-to-day care practice. Not to forget about the errors of fixation. To err is human, we do understand that. And errors can occur regardless of the number of years of experience. So to give an example, sometimes you are fixated this and only this. Like in case if the infusion pump is giving alarm, we still keep flushing the line without realizing that IV could be out. It could be a misplaced IV cannula, or there could be a kink. Everything but this. For like, you are not looking for a wrong drug administration when the drug does not solve the problem. We have given atropine and there is no response to bradycardia. Everything is okay. Example, there is a low saturation and we say it is because of the equipment malfunction, or the finger is cold, or because of peripheral vasoconstriction, instead of thinking that the tube could be endobronchial. So there can be severe hypoxemia there. We can have biases. So there can be availability bias, tendency to judge things based on what comes to mind readily, depending on the previous bad experience. Like we have a high airway pressure due to bronchospasm and we are managing it with bronchodilators, steroid puffs, and we are not ruling out a kinked endotracheal tube. Confirmation bias, where we are trying to force data to fit a desired or a suspected diagnosis. We keep repeatedly checking the blood pressure and changing the blood pressure cuff and not accepting that, yes, actually there is hypertension. Overconfidence bias, where we are technically not skilled or experienced and we are trying to guide someone else. Omission bias, there can be delay in ordering blood in spite that you know that the blood loss is ongoing, the blood pressure has fallen down, still there is a delay. So how do we mitigate these medical errors and enhance patient safety? Well, we must understand the complexity of the system. Routine checks are absolutely mandatory. We strengthen each layer of safety, as we said earlier. That's a primary prevention. We improve the workplace culture, flatten the team hierarchy, have the situational awareness, improve teamwork and communication, team pre-briefing and debriefing after every case, schedule the complex patients at the start of the OT list. I mean, surgically, the patient could be easy to go, but anesthesia-wise, if it's a challenge and difficult case, we must post in the first case in the morning. The favorable design of equipment and drug ampules and packaging, that's very important, because if it's not readable, we understand Lhasa and it can occur look alike, sound alike, drug errors can happen, and that can be really life-threatening. Training of all the healthcare OR teams and the healthcare workers should be there. There should be adherence to SOPs and protocols and cognitive aids. There has to be proper documentation. This is very important for secondary prevention. That means there should be reporting and, of course, non-punitive action for the healthcare workers. Regular audits should be there to prevent the human errors. There should be learning also from the successful cases. Root cause analysis should be done. Reflections should be done to prevent, again, the repeat in the future or near miss cases that happen. the staff work hours should be good. There should be good well-being. I mean, the well-being of the staff who are working. All these matters. And lastly, the indemnity insurance is surgery prevention for the healthcare worker. Anesthesia is a team sport, and human factors are rarely in it. So we must learn them. The best way is a simulation. And of course, in the routine daily practice, it is good to discuss, analyze, and reflect routinely. Error does not necessarily equate to harm, nor does an absence of error result in safety. So we must look at the individual component. We must not look at the individual component, but understand the healthcare as a system and try to improve that. As I think the next speaker is going to talk, we have limitations of research in pediatric, which is a vulnerable population, of course. So most of the research is extrapolated from the adults, which is usually based on the weight or body surface area. So a 60 kg adult is not equal to a 60 kg child. We have to remember that. There is lack of sufficient safety and efficacy data in children. The outcome measures are difficult to assess in pediatric patients many a times, and they are into developmental stages which can alter the action and response to a drug. So that's why there is more use of off-label use of drugs, and difficult and a challenge for the pharmaceutical industry to put the age-appropriate dosage forms and strengths. Coming to the off-label use of drug, yes, there are delays in updating these drug instructions and gaps in reporting and evidence of off-label drug recommendations in pediatric guidelines. So this is the editorial of the Indian Journal of Anesthesia 2015. It recommends that we should have evidence-based recommendations for off-label use. We should develop frameworks for assessing the risk and benefits of off-label drugs in children. We must train the physician the appropriate use of this off-label drugs and clarify the current evidence for pediatric off-label drug use in guidelines. Incorporate them in the pediatric guidelines to assist in the judicious use of this off-label drug. So before prescribing, we should be aware that it is off-label drug, and that is the only best option that we have, and there's no other option available. We must sign the patient's parents must sign the consent form, and the informed consent process should happen. There should be close monitoring all throughout when the patient is being administered this drug. There should be good documentation and reporting and publication whenever possible. So in spite of all these precautions, learning that we do, there can be crises that we can face anytime during anesthesia. And that's why it's very important to understand the crisis resource management principles, never to forget this. In case of any critical incident or crisis, call for help early, establish leadership and role clarity, share the mental model, communicate effectively with a closed loop communication, distribute the workload, anticipate and plan, know your environment so that you can have gadgets or you can have people around to help you, allocate the attention wisely, mobilize resources and use them effectively, use cognitive aids to offload, because when in crisis, we are in the zone of freeze. Reevaluate and adapt. So this is extremely important. What we do is that when a patient goes through a surgical journey, we have to do a very detailed pre-anesthetic evaluation from the informant, parent, or any other family member, with the detailed antenatal history, birth history, vaccination, development, milestones, achievement, weight, growth chart, airway-related history, and examination. All this is done for the anesthesia risk stratification. And following this, informed consent process should happen. Informed consent is not simply a document, but it's a process where the consent is signed after the parents are explained the anesthesia plan and technique, what are the options available, what are the common minor complications, what are the rare major complications, if there's going to be need for blood transfusion, postoperatively ventilation, pain management, and likely postoperative course. What are the OT etiquettes that we must follow? Well, after the case is if the case is planned on the day of the surgery, the anesthesia workstation and monitor is checked, prepared, airway cart drugs, IV fluids, and working suction. Everything is checked. OR team who is there with the expert anesthesiologist. Safety checklist is performed. Cognitive aids are handy and guidelines are handy. Pre-briefing is done with role allocation, who's going to do what. We share the mental model with the OR team. Parental separation is done by giving oral or intranasal or intravenous medication. Pre-oxygenation never skipped. Monitoring is done before we give any anesthetic, and IV infusion as per the calculation. We never back the monitor and at the same time insist on clinical monitoring. A very controlled extubation is done at the end of the surgery, and post anesthesia monitoring is continued for at least an hour in the ICU recovery room. So the patients, this is a patient who is there with us right from 2 years of age. He has been coming. Sorry. And they are very comfortable and uh, very comfortable with the OT environment and the people around. And it is done in a very playful way, which really makes them very comfortable. So we have to always have the patient-centric approach to administer safe anesthesia, and that can be achieved only when we have the expert technical skills along with the non-technical skills and understanding of human factors. How do we enhance the skills which are required for the smooth conduct? Well, bedside learnings, observations, reflections are definitely must, and workshops, especially hands-on workshops and simulation, that's the best way to learn because it's in a non-threatening environment. The patients are safe and still you learn the techniques the right way. So would just like to share a few cases. There was one 8-month-old child who was posted for cleft lip and palate when undiagnosed subglottic stenosis. So when we understood that we cannot intubate, it was a failed intubation. So we continued the mask ventilation, gentle mask ventilation, and we woke up the patient, reversed and woke up the patient, and tracheostomy was avoided. Multidisciplinary team was called for a pediatrician, a pediatric surgeon, an ENT surgeon. Everybody were called in, and of course, with the plastic surgeon who was going to operate, and the parents, with everybody's consensus, we rescheduled the patient after the investigations, and that's how we avoided a kind of a complication, tracheostomy and its complications. We had another child who was 7-year-old Burns, who had a severe burns, post-burn contractures rather, by the time he presented to us, and had keloid tendency. And he underwent multiple contracture releases under general anesthesia with, of course, he was very extremely difficult. As you can see, there are a lot of contractures. This is still a released one. But when he was posted, now these patients do not even allow dressings under when they are awake. We need their cooperation, and that's why every time they come for a dressing change also, we need to give general anesthesia, which we do generally with the total intravenous anesthesia. And that's where we had once laryngospasm that can happen because of inadequate depth of anesthesia. So the learning from here was that previous uneventful anesthesia does not guarantee a similar course for your present anesthesia. So every time we assess the patient, we have to assess as a fresh case. There was one 11-year-old Burns patient who was there for delayed excision. And again, there was failed extubation in him. And we had to wake him up after we tried to put the supraglottic airway device, which is a rescue device. We use it at times, but it was not achieving the oxygenation that we wanted. So again, we allowed the patient to wake up and reschedule after acquiring a proper gadgets, that is a fiber optic bronchoscope, and then a senior person who could help us in achieving this intubation. There was a 35-day-old child for Sinike, where of course he had, because of the Sinike, there was no mouth opening. So this patient was again multidisciplinary team management. We had the ENT surgeon standby. But here I would like to insist, we did lignocaine topicalization, and airway was anesthetized topically, and thereafter even the transtracheal, as you see in the picture, we are giving a transtracheal injection in this baby. So again, the child was done very well, and the release was done well by the plastic surgeon. This is one 8-year-old girl for TMJ ankylosis. Of course, this is post-surgery, almost 6 months post-surgery. She had portal vein hypertension and worry about the nasal intubation during the fiber optic. So we use vasoconstrictor and very gentle manipulation and done by the expert. So again, this was uneventful and good. We had the child was in the previous slide where we saw the 4 photographs and the parental separation. That is this girl who had when the first surgery was done at some other center, and she ever since then she had PTSD, and now we saw her. She was very comfortable sitting in the OR with in the receiving area with the mother, and comfortable with the anesthesiologist as well. So there are some of the cases that we come across, syndromic and neurofibromas. This being a tertiary care hospital, a lot of difficult cases reach us. So to summarize, we must remember that children are not miniature adults. They have unique anatomical, physiological, functional features and should be recognized for safe anesthesia management. Idiosyncratic reactions can occur to anesthetic drugs, and it may be the first anesthetic exposure. Detailed history and examination, informed consent process, planning, preparedness, expertise and equipment, and drug dose calculation. These are extremely important aspects of pediatric anesthesia and should be done as a routine. There cannot be any shortcut to it. The syringe labeling has to be proper. How the dilutions are done has to be standardized and uniform. Topicalization of the airway can reduce the airway-related complications, which are very common in pediatric patients, so this can be routinely followed. Every action should be directed towards the risk mitigation and patient safety. Technical skills, non-technical skills, and understanding of human factors are required for a safe conduct of anesthesia in children. Practice, reflections, drills, simulation, crisis resource management are answer to how we can enhance all the 3 skills. And an occasional pediatric anesthesiologist must take help from the expert in case of any anticipated difficulty or critical incident. So we understand that most of the problems are preventable, and that's why we must act in a way where the patient is most safe, because patient safety is paramount. So these are some of my references, and thank you very much for listening to me. Thanks for your kind
Thank you.
attention.
Thank you so much, Rita. I think that's a really nice introduction also to the pediatric anesthesiologist and what kind of challenge that you face. I think I agree with you that we need a very systematic and good preparation before applications of anesthesiologist drugs. Please stay with us, Sweta, and I will again invite the audience. If you have burning questions, more than welcome. Just post your question in the chat column of your or YouTube channel or in the Facebook. And we're going to discuss further your questions later. I will invite now our second speaker. Let me introduce you to our second speaker, Professor Atia Faruqi. Professor Atia, you there?
Yeah, hi Grace.
Hi, yeah.
Hi
So,
everybody.
Hi. So, Professor Atia is a professor of pharmacology at St. John's Medical College in Bangalore. She will have a talk entitled Clinical Trials in Pediatric Populations. She's a professor in the Department of Pharmacology and completed her MBBS from Bangalore Medical College and also her master from CMC Vellore in 2006. She has been an investigator for different multinational sponsored and academic clinical trials, as well as an observational studies. And apart from her routine academic work, she also set up and studied the therapeutic drug monitoring services at St. John Medical College hospitals and in charge of the drug information services, and also play an active role in the drug and therapeutic committee at the hospital. I think she also have a keen interest in ethics and research and promoting a good research method, which is quite interesting, especially if we have such a lack of knowledge actually about the research in children. And so without further ado, this is a very exciting topic. Professor Atia, the time is yours.
Thank you, Grace, for that kind introduction. I hope I am audible and my slides are visible.
Yes, it is.
All right. So, good evening, everybody. And I come here from representing my hospital, St. John's Medical College in Bangalore, South India. And ours is a 60 years old institution, and it has a medical college, a hospital, and an independent research institute. The research institute is about 20 years old, and it's the first research institute attached to a medical college. And we have also been recognized by the Government of India and ICMR as a center of excellence. And as a part of our Division of Clinical Research and Training in the Research Institute, we conduct health research method courses every year for the last 16 years and several other research methodology courses. Our division has been a part of large multicentric clinical trials, and I'm proud of being in the team of well-placed researchers. I do my bit of contribution in research as well as teaching. I teach in the medical school, nursing college, as well as we have a therapeutic drug monitoring laboratory in the hospital. So let me get started with this topic, clinical trials in pediatric population. And all of you know that pediatric population has unique challenges in their research. There are ethical complexities, there's difficulty in recruitment, or also limited funding in pediatric clinical trials as compared to adult funding. So I would like to introduce you to certain basic concepts, certain methodological issues, and few solutions, and what is practically possible. There are still some challenges, but we go ahead with our efforts to bring evidence. So I'll cover my talk in these subheadings: background of why we are doing this today, and what's the importance of pediatric trials, what are the issues with conduct of trials, especially design challenges. Ethical considerations are really important in this population. What are the regulatory framework, what do they say, and a few certain small solutions for the future. So clinical trials, as you all know, are systematic studies to evaluate safety and efficacy of new drugs, vaccines, or treatments. These RCTs, randomized clinical trials, are highest level of evaluation of any treatments. In fact, this is one of the greatest achievements of our modern medicine, that we are able to have evidence, and we use this evidence for proper care of our patients. And we all know that treatment guidelines are based on high quality RCTs. So guidelines for adults as well as pediatrics require good, robust data from well conducted randomized clinical trials. You see, this is a slide which shows a proportion of what is the disease burden, which is pediatric, and trials that are conducted in pediatric. So if you see that overall the disease burden, which is pediatric, is nearing 60%, but the number of trials that are in pediatric population are only 12%. Says the case is say with high income countries, and when you look at middle income countries, you have even lesser numbers. So while the disease burden is about 62% in pediatric age group in low and middle income countries, the number of trials that are available are only about less than 12%. And a condition which is primarily considered as diarrheal illness is considered as pediatric problem. 90.4% of it is pediatric burden. We have only less than 60% of trials which are conducted in this disease condition. So let me introduce to the concept of off-label use. We've heard this name before, so like a formal introduction. What is off-label use? It is prescription of drugs that are outside the specifications of the product license and for a different age, dose, route, or indication. So we know that we have historically children have been excluded from clinical trials, either due to ethical concerns, logistic complexities, or there are lack of financial incentives. So what we use our drugs are based on mostly as an empirical dosing or a scaling method. So all of us are familiar with scaling method where we use formulae based on age, formulae based on weight. Those are all scaling up methods. And when we use an adult dose and we try to scale it down to pediatric, we still don't have a, a complete scrutiny of that indication. So it is documented that 50 to 75% of drugs which are used in children are off-label. That means that we do not have a specific testing or testing of that drug in children or approval of those drugs in children as per the product license. Okay, so this is an off-label use because it is for a different age. The dose would be different and also route. Okay, I will talk about that a little later. We don't have enough, that is limited or sometimes non-existent so information supporting a given dose. So we are only using an empirical or a scaling dose. Okay. Now, what is the risk? If there is a risk of incorrect dosing, and there could be unexpected side effects. Incorrect dosing because most of these scaling methods, which are based on age or weight, do not account for the differences in which the organs will deal with the medication. There is immature enzymes, there is different pharmacokinetics. So the dosing that we extrapolate from adults may need not be the correct dosing. And we all know that some children deal with some of these drugs with unexpected side effects. For example, with a simple antibiotic like chloramphenicol, we see gray baby syndrome, which is not there in adults. Tetracyclines are another important group of antibiotics which cause discoloration of teeth in children, but not so in adults. Okay. Similarly, the analgesic aspirin can cause Rey syndrome, that's involvement of the liver, which is an unexpected side effect of aspirin in children, not seen in adults. Okay, so overall, these by not having pediatric trials, we are actually bypassing the safeguards of drug regulatory process. All of us know that drug regulatory process is a very meticulous, thorough investigation to confirm the safety first and then efficacy of the drug in the given dose, in the given route for a particular patient. So an off-label use is dangerous because there can be errors in dosing or there can be unexpected side effects. Okay. So this puts the foundation of why pediatric trials. We already just now saw that we have paucity of data. And as Dr. Shweta had mentioned, children are not small adults. We cannot calculate exact doses for them. There are differences in absorption. This is kinetic differences. Their pharmacodynamics are undergoing developmental changes. This receptor sensitivity can be different. There are organ immaturities with liver, even elimination through kidneys impacted. So therefore, we say that traditional formulae for calculation of dose on weight and age do not account for these ontogenic changes. The ontogenic means growth and development and maturation of different enzymatic machinery as well as organ maturities. Then we have a difference in formulation for pediatrics, and the dosing therefore will also be different. There is an ethical necessity, just now, as I mentioned, if we don't have enough evidence for safety, then we can expect unexpected side effects. A well-designed trial, therefore, will help in creating safe, effective, and age-appropriate medicines. and also will identify and prevent adverse drug reactions in pediatric population. And as seen with adult patients in clinical trials, participants in trials derive benefits by just being in the trial. They get better clinical care, and sometimes they have an access to new treatments, especially oncology trials. These treatments, which are not routinely available, may be accessible through the trials. Okay. So in conduct of pediatric trials, there are three things that we will look into. First would be the issues with the trial design. So there are certain challenges when we are designing these pediatric clinical trials. First and most important challenge is a small sample size. The number of patients, the number of children who are suffering from a disease condition or a particular cancer or rare genetic disorder would be fewer. Okay, so the numbers available are fewer, may not be enough to do a full-fledged trial. Plus, amongst the children, there is again age stratification, where we stratify them as neonates, infants, children, and adolescents. So there is a huge difference between neonates and infants, as well as neonates and adolescents. There can be a difference in their weight and their blood volume, the formulations that we can use for them, and the kind of pharmacokinetic responses that each of them will have. So when we are designing a trial, we have to look at all these, including all these age groups, or if we are focusing on one, then we need to specify that. And a third challenge would be to identify correct outcomes as endpoints and use certain biomarkers. We'll come to that in the next few slides. Now, if you want to get the right number, there are certain solutions. So I would be providing solutions by side as the challenges. The sample size can be increased by doing multi-center studies. There are global collaborations which help in getting people of similar research question together. It makes the trials feasible, and having a diverse population can increase the reliability of a trial. There is a consortium called Innovative Therapies for Children with Cancer, and this ITCC consortium can help build bridges between different countries and different hospitals for looking at a particular cancer of interest. The WHO has set up an international clinical trials registry platform. This again is set up for facilitating research across different geographical areas. There are certain other organizations, for example, Connect for Children, available here. C4C, it is called for short form. This again facilitates in bringing pediatric population of similar issues together and help in setting up trials which can be successful in getting adequate numbers required for sample size. Now, looking at what kind of outcomes should we see when we are designing a trial. Okay. So there are certain clinical endpoints which we can take as direct measure of clinical benefit, like a survival or a symptomatic relief or a disease abscess, that means complete cure of the disease. These are called clinical endpoints. And we compare this with surrogate endpoints. Now, surrogate endpoints are indirect measures, and these will predict clinical benefit. For example, certain biomarkers or intermediate biological measures. These can be also taken as an outcome for showing the clinical benefit, but it is an indirect measure. And also we have issues, like I just mentioned, that we have 4 strata of children with size and age. And so we have to select age appropriate endpoints as well. Going a little more into outcomes, the clinical aspects versus surrogate endpoints. When we compare use in pediatric trials, clinical endpoints are preferable if they are feasible because they are more definitive. Surrogate endpoints are used when clinical endpoints are impractical or they are slow. Okay? There is no requirement of validation when you are taking a clinical endpoint because it is direct evidence. However, when we take surrogate endpoint, we require validation or strong evidence linking it to clinical outcome. And third is that trial success impact can be seen with true benefit and with a clinical endpoint, whereas surrogate endpoint we'll have to have a bit of a caution. There may be chances of misprediction if they are not validated, but validated surrogate endpoints are very practical solutions to looking at clinical endpoints in pediatric trials. Now, when we look at age-appropriate endpoints, there are several things that we can do. Okay, so we could look at developmental suitability. We can match endpoints to physical or cognitive developmental stages, and especially required for the different strata of children. Then validation and reliability can be done by using standardized, tested, and age-appropriate tools. Again, and there is a very important aspect in designing of pediatric trials, and that is called stakeholder engagement. So when we are designing a pediatric clinical trial, we include experts, we include patients, and certain times even caregivers when we are deciding and designing an endpoint. This helps in better identification of outcomes, benefit, and how it is practically applicable. We can adapt adult endpoints for looking at pediatric changes, and we need to, of course, consider pediatric differences. But we have seen that clinical trials which look at similar endpoints as adult clinical trials have been more successful. And last is that we could take multiple endpoints. We can combine the endpoint of clinical, pharmacodynamic, and also combine with patient reported outcomes or observed reported outcomes by the caregivers as endpoints. And this again needs to be age appropriate. So these were the challenges that we looked at, design challenges and certain strategies to help in identifying and writing the endpoints that we would want to and selecting them as age appropriate. Now, there are practical challenges, logistic, and what can be those? There are practical limitations of the amount of volume of blood, amount of blood that you can draw in at a time, and also total number of blood draws, pricks. So we know that when you do a pharmacokinetic study and we are looking at how the drug's journey is through the blood, we need multiple blood draws, and that may not be possible in smaller children. And with caution, we have to use for little older children as well. Okay. And again, as I said, weight determines, age determines, and there is this depiction which tells us the comparison. So this is a table which compares based on age, weight of the child as to what the normal circulating blood volume would be and maximum allowable sample over 2 weeks. So if you look at a preterm neonate, which is usually about 1.5 kgs, the maximum allowable blood draw in 2 weeks is only 3.6 ml. Okay, so that is really, really small. If you compare as you go up the size of the child and age, the weight increases, and a typical child of 12 years weighing 40 kgs up to 96 ml. So that is about 100 ml we could withdraw. So there is so much of variation in the amount of blood draw that we can do. And this data will reference us to what is allowable limit. Now, since there are these limitations, what can be the sampling innovations? So there are certain innovations which I'll talk about. One is an opportunistic sampling. Here we would try to reduce the number of pricks that a child would be getting. For example, for a routine blood test that the patient would have admitted in a hospital, for some other tests, we could do our sampling along with that sampling. So this is called opportunistic sampling, where we will try to reduce the pain and the anxiety with the number of pricks. Okay? Then we have a concept of micro volume sampling. As less as 300 to 400 microliters is enough for the newer machines that we have for analysis of the drugs. So we look at taking micro sampling, and typically we can take it through scavenging of samples. That means that The blood tests that were done for others, when samples are left over, we could use those samples because we need very tiny sample. But of course, for a kinetic study, we need to know precise details of time of collection. So when we are given the precise time, we will be able to use these samples for evaluating or quantifying the drug in the blood. The concept of sparse sampling was introduced because of the advent of what we have, the model-informed precision dosing, that is based on pharmacokinetic, population pharmacokinetic data, and it has models for identifying the entire exposure of the drug using a few blood samples. We are using this sampling technique combined with model-informed precision dosing for our routine therapeutic drug management in our hospital. So that means that we take few samples, for example, vancomycin. We take 2 samples of vancomycin and we are able to, using the software, calculate the total area under the curve. That means the total exposure of the antibiotic. We were able to calculate just by using using 2 samples with the software, whereas without the software, we would have needed about 10 samples. Using dried blood spots is another newer technique, and these require as less as 20 to 30 microliters of blood. Just only caveat is that the packed cell volume of the blood should be fine, the number of cells per area, so that we are able to get a good sample. There are certain other practical challenges. There are formulation challenges. It means we need to have syrups which are palatable, okay? And the dosing has to be correct with that formulation. Dose accuracy, as I discussed earlier, there is a wide variation in weight, and therefore this can be a challenge when there is different formulation. Administration of the drugs depends on taste, palatability, number of times, frequency. Certain newer formulation like mini tablets, chewables, orodispersibles, liquid formulations try to overcome these challenges. And the third important thing in pediatric trials is that we need long-term follow-up, because we need to see what are the effects of the drug on the child's growth at that particular age and also development. So safety monitoring is most foremost, and this is why we are talking about pediatric clinical trials on this patient safety day. When we do typical pediatric trials, we need to have certain safeguards with us. The most important thing is that we should have a data safety monitoring board which provides an independent oversight on the safety and success or going towards some successful, meaningful conclusion of any pediatric trial. Adverse events reporting becomes again very, very important during our pediatric clinical trial, as I mentioned earlier, that there are certain differences seen in children, certain certain reactions seen in response to regular drugs, which is not seen in adults. And long-term follow-up, as I just mentioned, we need to monitor growth, neurodevelopment, puberty, long-term safety. All these are very, very critical for pediatric clinical trials. Now we come to an important aspect of ethical considerations, and many times, as I mentioned earlier, ethical complexities make the sponsors think twice and whether to include pediatric population at all. But keeping it very simple, let me just take you through a couple of slides of what is important. Vulnerability of children. They are vulnerable because they have no legal capacity and they need care. They are dependent on others for their well-being. So we need stronger safeguards. The trial should be done in child-friendly settings, in the presence of parents, where they have emotional security. And we have to balance risks and benefit. And the body which is actually entrusted with this identifying balancing of risks and benefits is the ethics committee. So an ethics committee will do a meticulous review. They do go thoroughly into the procedures, and especially for measures that will safeguard the children participating. There has to be a justification for participation of children, and a consent process should be in place. A little bit more detail of what an informed consent means for children. Consent process, usually the moment we think of a trial and we think of including a patient, we need to first get the consent from parents or legally authorized guardians. Then we have a provision of something called assent. So assent is like informing the child and taking permission from the child for participating in the research. And this actually upholds the important ethical principle of autonomy. So although a child is as small as 7 years old, totally dependent, will look at her or his or her parents for their consent, but a child of that age and then adolescents like 12 to 18 years are in capacity of understanding a bit. So we speak to them in a language that they understand. For children who are between 7 and 12 years, we can take a verbal or an oral assent, and we use visual aids like diagrams, infographics, or certain videos to explain complex concepts more effectively. One of the important resource that is available on the net, which you all can look at, is something called Sophie's Science Project. This is a cartoon depiction of what the whole trial is, to make the child understand what a research study is. This has been developed by the Cincinnati Children's Foundation and Children's Hospital Boston. This is available as free tool in the on the internet, and it takes the child through using infographics, cartoons to make them understand complex concepts in simple language. So the bottom line is that verbal oral assent should be as simple as possible for a child to understand what is being asked of him when he or she participates in the trial. This assent should be obtained in the presence of parents, okay, and it also should be recorded for safeguarding the investigators. For children between 12 and 18 years, they are at a level which they can understand a little better. And so we take a written assent from them. This written assent is similar to the informed consent document for the parents, but in a simpler language, which can be understood by the child. And this also needs to be signed by the parents once you finish the written assent. Now we look at the other parts of it, which is the regulatory framework. So we have a guidance from ICH. The document is called ICH E11. It has undergone revision 1, and that's the latest still available as of now. This gives us guidance on clinical investigation of medicinal products in the pediatric population. So this ICH is the reference that we can go to when we need to design and conduct a pediatric clinical trial. In case of any questions on procedures and rights of participants, all information is given in this document. Similarly, across the globe, we have regulatory framework, and I'll just mention a few of them, what are available, and we can reference them, use them for going forward with our design and conduct. National Institute of Health has a policy. The NIH in the US has a policy of inclusion of children in all human subjects, supported by NIH. The US FDA has come with the Pediatric Research Equity Act, and this tells all the pharmaceutical firms to include children in studies of all relevant indications. Where they are not going to include children, they need to justify why children are not included in this particular evaluation of a new drug. Okay. There is another act called Best Pharmaceuticals for Children Act, BPCA, by the US FDA, and this helps in incentivizing research in children, and they do by additional marketing exclusivity to sponsors who voluntarily complete pediatric clinical studies. Now, this is additional marketing exclusivity for about 6 months or more is there to keep research, to keep the financial interests of the sponsors. They have invested a little more in including children, and therefore they can be given exclusivity for their marketing. Both of these are for improving research in pediatric patients, okay, pediatric populations. Certain other agencies like European Medicine Agency has given guidance on pediatric investigation plan. It's called PIP, and it ensures the data is generated to support authorization of new medicine from pediatric population. It obligates companies to screen every new product for a potential pediatric use. And WHO has an initiative where it helps in boosting availability of drugs for pediatric treatment, accelerating research, development, and access to pediatric medicines. There are certain regulations in India, and I would like to highlight that because it emphasizes child-specific protections in research. And here the guidance is that children are permitted to be a part of the research only if safety has been established in adult population, or if the information is likely to be generated which cannot be obtained by other means. The ethics committee needs to approve after thoroughly looking at safety and rights of pediatric patients, and also that rights of participants are protected and compensation for trial-related harms are addressed. Certain special populations, which I will not go through in detail, but they have unique physiology, neonates, those with chronic illness like oncology or rare diseases, nutrition status matters in clinical trials, and certain children who are more vulnerable, like orphans, socially vulnerable, they're orphans or they're disabled, also needs to be considered. So here we have three success stories of clinical trials in children. Vaccine, we have the rotavirus with us, we have the HPV vaccine with us. All is possible because of improved child health worldwide. Antiretrovirals have helped us in dosing safely HIV children, and oncology trials are the ones because of which we are able to improve 5-year survival from 25% to more than 70% as a result of multi-center trials. So I would like to conclude by saying that negatively biased media coverage about clinical trials in children has to be balanced with public awareness campaigns, positive stories of societal benefits of RCTs, and we have to highlight the harm that can happen if we use not if we use adult data. That means if you don't use data from pediatric clinical trials, there could be unexpected adverse effects. Okay, so there is one additional thing which I would like to inform you is that now we are basing a lot of our trials on in silico pharmacology, also called as computational therapeutics or computational pharmacology. And this is on the basis of what I was talking about, sparse sampling using a computer software. So using softwares to capture, analyze, and integrate biological medical data. And we have two modeling approaches. One is called population pharmacokinetics, and the other is called physiologically based pharmacokinetic modeling, PBPK. And these are applicable to both pediatric and adult clinical trials. Summary to end with, pediatric trials are essential to ensure safe and effective treatments for children, must balance protection and innovation. And in future, we are looking forward to safer, child-friendly, globally coordinated trials. I would end here with my references, quite a lot of them, and thank you.
Thank you so much, Professor Atia. It's very extensive elaboration on how we can conduct clinical trials among children. I saw that in the chat box, some people already have questions, but I would like to invite again Dr. Sweta, Professor Sweta, and also Prof. Atia to our discussion session. Before we go to the audience question, I actually have a personal questions that I would like to also ask, especially Dr. Sweta, because I
Yes.
think both of you actually mentioned that most of the drug that we use is actually off-label for pediatrics, right? So I'm just wondering, I'm just curious, how will you explain about off-label to the parents and also to the children if they can give assent. Maybe you can share also the experience, Professor Swita.
Yeah, so when we are using these drugs, we have to, as I mentioned in the informed consent, that these drugs, we do not have the trials or the research for that. So, but without this, we do not have an option. As I said before, prescribing any off-label, we should be clear that it is the only option or it's the best option that's available. And we also explain that this is being routinely used in clinical practice, though there are no clinical trials being there. And we have done many cases where they have been very safe in these pediatric patients. So that has to be the way, that's how we explain them. And when the off-label is just one component of informed consent. When we talk about the other things, they do understand, the parents do understand that whatever we are doing or we are talking and we are going to ultimately conduct the anesthesia, it's all in the best interest of the child. They do understand our intentions and motive, and beyond that, they many a times they tell whatever is the best for the child, we give you the authority to do it. That is how they have that kind of faith in us, because they've seen us how we are dealing with the child, what all we are inquiring, what are our concerns. So that's the kind of connect we have with the patient. As I said, informed consent is a process, it's just not a document. So off-label use of drug also becomes just one part of the informed consent. And when we do this, there is always a positive response that we have seen from the patients. There could be some more questions that may come from them, that will it be safe, or you think that what will happen to my child in this drugs are used. Then we explain them, we give them the opportunity to ask more questions and get it clarified. But sometimes if they are not ready for regional anesthesia, then we explain, we change our techniques also. So we always offer them all the possible options that they have it. And at the end, if at all, I will say that if it was my child, I would have gone ahead with this. So that's the final thing that I would say, and then leave it on to them to decide, because we are only the trustees. Ultimately, they have to take the decision. So it's always left on to them. And I always like to share all my thoughts. I think aloud with the parents and I discuss everything with the parents. So the decision has to be coming from there. So even if there is a problem that has come later on, the parents are convinced that it was done in the best way, basically, that there was no negligence from our side or any shortcomings from our side. That is what they understand. So the what you say, that bitterness is not there. They do have faith that our intent are correct. Yeah, so that's how we go about explaining the off-label use of drugs.
Yeah, thank you, Professor Swita. I think, yeah, that's good communication will increase trust, and that's the key to kind of ask you for
Can
a
I
consent.
can
Yeah,
I just
sure.
add to
Sure,
that?
Professor. Yeah,
So,
sure, go ahead. Yeah.
so while I described off-label use for children, I did talk about it that nearly 50 to 75% of drugs that we use in children don't have regulatory approval. Okay, that means we don't
Yeah.
have direct evidence from well-conducted RCTs on their use. These are scaled up doses, so we calculate based on age and weight. Whenever we do use these drugs, it is not like it's illegal. In fact, that would be the only drug which is available, and it is pretty appropriate to use. Okay. The only issue here, and why we emphasized on off-label, is that there are times when certain side effects that could have been picked up if it had undergone regulatory trial, regulatory process, because it's quite stringent to go through the trial. They look at the benefits, they look at the risks, what is the advantage, how much benefit has happened with the drug. And so the confidence in its safety is that much better. But such trials, the drugs available from such trials are about 25 to 50% only. So, as I said, nearly a rather larger number drugs which we use in children are still off-label, and we call that as empirical use. We calculate using the scaled formulae, but it's not inappropriate. Okay? So that's something which we need to convince the patients.
Yeah, thank you, Professor, for the additional. So actually, I want to follow up also on that. So did you see a lot of challenge also in convincing the regulatory and starting your trials using those basically off-label use? Or is it even simpler if you can convince them that it's already actually appropriate in
Yes.
other country or
Yes.
setting? Yeah.
No, see, the thing is that when we are looking at focused trial of particular drug, it is going to be beneficial. So the regulatory don't have a problem. What they are looking at, regulators are looking at, is whether enough safety measures for the patient are there, including ethical principles being upheld, and monitoring of adverse events. Like I said, if you have a data safety monitoring board along with the trial, that is an independent committee looking at how the trial is going, what are the outcomes reported, safety is being established, then that gives the confidence to the regulators. Okay, so doing a pediatric trial actually is encouraged because we need more trials and we need more evidence. Like I mentioned, in India, we have this limitation that we can use or we can conduct a pediatric clinical trial only after the drug has been tested in adult population. It has been tested as safe and the dose has been identified. Only then can we do a pediatric clinical trial in India. Okay, but globally there are certain trials which actually take both adult and children together, and they have, of course, different versions of consent and consent added to that. But many trials which are looking at the same outcome measures are successful. So doing pediatric clinical trials is lesser of a problem from regulatory aspect.
Okay, I can see that.
So can
So
I
there's
just
a
add
question.
to can
Yeah,
I just
sure.
add to
Go
that?
ahead. Go ahead, Professor.
Yeah. So just that in pediatric trials or otherwise, wherever there is vulnerable population involved, there is always we have this on-site supervision also going on. The ethics committee will go to the on-site and check the papers, and they will interact with patient also. That can increase the safety. Apart from looking at the documents, the primary documents, they will interact with the patients also. So that can be an additional thing that can ensure that whatever has been conveyed to the ethics committee is actually there. And they have given the direct number, the patients are given the direct number of the ethics committee if they want to report anything or have any doubts about any regarding the drug issues or the trial related stuff. So on-site visits are generally a good idea for vulnerable populations.
So did you see, Professor Svita, that actually the ethics committee monitor the trials actually more often than if they do for the adults trials, or are they the same?
No, they definitely, all vulnerable population, whether it's pediatric patients, pregnant patients, so they will definitely have the on-site visits for that. That's what we have seen.
Okay, thank you. So there's two questions actually from the audience online. The first question is from Ani Wulandari. She asks about risk management plan. So I think this is a question especially for Profetia. When you're conducting a clinical trial for children, is it required for you to submit a risk management plan? What was your experience?
Yes. Risk management plan is definitely required because there is an additional scrutiny, and more people are worried about whether safety measures are in place and expecting the unexpected adverse effects. So we will need to gain the confidence by submitting a well described risk management plan. So we identify the potential adverse effects and uh, plans for unexpected events. Then, like Dr. Shweta said, ethics committee has a closer scrutiny on these trials which have vulnerable population, and reporting of any adverse event and uh, such issues have to be done to both ethics committee and to the regulator within a stipulated time. So very critical document for all trials, especially pediatric clinical trials.
Okay, thank you. Dr. Srita, do you have anything to add? Have you encountered this like a risk management activities in clinics, especially for
Yeah, definitely. So
service?
because of that,
Yeah.
to take care of the risk management, many a times even anesthesia person is made part of the trial for the resuscitation required or any adverse event that can come up. So many of we become the co-investigator to them because we help them for being standby for any of this serious adverse events that can come up. One worry that I generally that we have here for pediatric trial in India, otherwise I think the problems about the inducement, that is one big thing about the parents. So that can also kind of compromise the, of course, it's a vulnerable population, so we understand that the safety does get compromised here. So that is one worrisome thing to go ahead with the pediatric trial. So those things have to be very stringent, that the inclusion exclusion criteria should be very clear.
Thank you. So there's another question from Fishalani Devi Rashirvan. The question is actually for Professor Atia, but I think this is also can be valid for Professor Swita. The question is, in neonatal and infant trials, the trial duration become a major challenge because of it influences the growth and development changes after the alter the PKPD themselves, right? I think you mentioned this also, Prof. Tia, in your presentation somehow. How will you address this? And maybe for Professor Swita also, whether if you look at your patient who will participate in clinical trials, will that how long will actually you follow up for serious adverse events, especially if we expect some late onset adverse events? So maybe any of you want to respond to that first?
Yes, see, I have already mentioned that follow-up safety data is really, really important for pediatric uh, trials. So so it really depends on the kind of research question that is there and the kind of intervention that is there. So for a drug and intervention which is of acute origin, that means you do it for a short while and then you look at outcomes. The probability of requirement for a long-term follow-up will be less. But again, it depends on the nature of the drug again. When you're looking at neonatal and infants, the question has to be very, very clear as to what is your outcome that you're going to monitor. Okay. If your outcome, as I said, in acute setting is a short-term outcome, that has to be identified and reported. Further, as a safety measure, you will do a follow-up for growth monitoring as late as, I mean, as long as at least 3 months if for a short-term trial. But if it is a longer term trial, for example, you have a tuberculosis, which you're looking at in children, okay, with children between 2 and 4, or maybe infants between less than one year. There you have an impact on the liver parameters, you have an impact on the growth, you have an impact on the vision of the child. Okay, so a longer follow-up will be mandated. Children who are adolescents, we can expect certain treatments depending on the nature of the drug, where you're going to extrapolate from adult data, whether there is going to be an impact on growth and development, puberty onset, those become important. Okay, so the duration of trial as well as follow-up for safety depends on the nature of research. and the molecule that we are going to use. So like I said, if we are using, if we're going to do a trial in children after an adult safety has been established, more or less a kinetics for the thing and the entire exposure to the drug will be also quite documented as to how much can it impact the children. But given the variety or rather age range of pediatric trials from neonates to adolescents, there it really will be dependent on the type of trial as I mentioned earlier. So that's from my side. Dr. Shweta, please add some more.
Yeah, this is one very difficult question always, how long to follow up with the patients. Like if my student, if I want to do just an observational study to see how anesthesia affects the neurocognition as a child is growing, uh, the the MD residence, we have 3 years residency. So I can do follow-up for 2 years and then decide. But 2 years, we know it's not sufficient to understand the long-term outcome. And of course, the criterias are also very difficult. But definitely, there's so much of talk going on about whether if they exposed to anesthesia and all these polypharmacy drugs much early in life, what has been their neurocognition, how do they get affected? I mean, most of the time, gross functions remain normal, but you will never know what happens to the finer functions. It is very difficult to make out. So the only thing as a clinician I would suggest is that what I follow, so I'm just sharing the same with you, that when we are managing anesthesia at that point of time, we try and keep the parameters, what were there as pre-op, always remain in 10 to 20% of the range rather than going to allowing them to go extreme. Like saturation is remaining 99 to 100. You see to it that you never want to get it down below 96, because otherwise, child will come out fine of anesthesia, even if it goes below 96. But I don't know which finer functions would have got affected ultimately. So this is always a concern. And as a clinician, what I try and do is that maintain the parameters, but it is extremely difficult to say how long we can get we need to monitor them to understand what could be the side effects. But I guess if the neonate is there up to 3 years of age, you will see most of the milestones being achieved. Or if a toddler is there, maybe five years of age, you will see most of the things being presented. So somewhere it's just by a very what you say, as we've seen the patient. So very casually, I'm telling this, there is no reference or evidence, but that's what we have seen, that at least up to 3 years, one has to be monitoring if we are looking at some neurocognitive effects.
Yeah, so then it's kind of a difficult. Yeah, I know this is a difficult question, but it will be interesting if later we can have some kind of guidelines regarding this. I still invite people, if you audience, if you want to post questions. But I have another questions actually for Dr. Professor Sweta, and also maybe Professor Tia, you can later add on. It's about the dosing. I mean, like, because we know that error in dosing is kind of the major causes of medical errors. And of course, in pediatric, there will be more challenges because we don't have the dosing form, right, for the children. So what was your experience in this? Like how difficult it is to actually adjust the dosing, and how we can actually, limit the medical error related to the dosing calculation, because I understood that in clinic will be a very challenging issues coming from a adult dosing and then convert that to the pediatric dosing.
Very true. The dosing is really a sorry, dosing is really a problem. Though the standard doses are defined, but many a times the calculations go wrong. So before we take any patients, we see to it that it is double checked, that the dosages are calculated correctly, because it's a mathematical thing and you cannot have, because I've seen if the child had to be given kind of 0.3 milligram of pentazocine, this is way back, and if the child receives, because of that one decimal, child receives 3 milligram, and it's like patient will go on ventilator, the neonate will go on a ventilator post-operatively. So we have to see to it that the drug chart is put up, calculated, and it is put up before any pediatric patient is taken up. All drug dosages, all the drugs that we are likely to use are calculated as per the weight, and they are put up. And the dilution of the drug that we do for pediatric patient, it's done in that tuberculin syringe, so that and it is standard, uniform all over the hospital, so that there is no confusion about the change in the concentration that can give problem, because sometimes some of the residents may have habit of diluting it 10 times, some may have diluting it 5 times, and you don't know per ml how much is going. And in pediatric and neonates, definitely we do not want to increase the volume. So what we use is we use the tuberculin syringes where the marks are graduated, and that's where everyone uses the same protocol all over the hospital. And some of the drugs are put up in particular syringes, like if it is atropine, then it is there in say 2 ml syringe. And if there are muscle relaxants, they are labeled in red, so that there cannot be any confusion about a wrong drug going, because many times a flush is used, and relaxants have sometimes can go if it is not labeled correctly. So we know the relaxant is the most dangerous drug for us, so we keep it in a red label so that everybody knows. And it is good to have that uniform practice all over the hospital so that we can avoid this. And as we understand, LASA is very common. So, so we use even the magnifying glass at times, so that we can see the strength, or we can see the expiry and the date, because many a times they are not even readable correctly. So that's why it is important. So we use magnifying glass, which is kept with the anesthesia workstation. So, and it is, drugs are always confirmed by two people. So two in the team will always confirm the drug. And yeah, that's the way we try and reduce the drug errors. And we have to talk also that this is, if somebody is giving the drug, that person will say this is 2 milligram per ml and the expiry is so and so. The other person will also see it, that yeah, confirm, not just listen, but will counter check and see on the label that yet it is. So look alike and sound alike is a big problem. And dosages, as I said, the overdosing is a problem more than underdosing in pediatric patient. So these are the care we take. These are the protocols we follow. So
yeah, thank you so much. That's a very useful tips, I think, for especially for clinicians. Professor
yeah.
Atia, any comment
Yes,
for that?
so yes, similar, just to same thing to reiterate that it is the calculation that becomes an important part of it, and the dilution. So again, as she mentioned, that volume has to be low, and then understand that the required drug is diluted in that amount. So there are these calculation errors which are possible, and as she rightly said, two people doing and confirming is the best way. There is another issue with drugs, certain group of drugs where there is availability of certain formulations is not there. For example, we have antifungal agent isavuconazole. It is available as a syrup and a tablet, but in India, syrup is not available. Now, for a child who will require much lower dose, if you take the tablet and try to break it and dilute it into the required concentration, it is a huge challenge because it will be such minute concentrations. Okay, as well as the the tablet is an extended release preparation. That means you should not crush it, you should not powder it and redilute it. The kinetics of these drugs get actually impacted if we crush them. So there are too many nuances to pediatric drug dosing, and many of these are formulation related. We have another antifungal drug called posaconazole, which is available as syrup and tablet. And we've seen because we measure their blood levels, we see that the syrup is lesser bioavailable than the tablet. Okay, and uh, it's dosing with respect to food. So this antifungal posaconazole is better absorbed after food, whereas another antifungal voriconazole is absorbed better in empty stomach. And many times the nursing staff would do it the opposite way. So correct dosing, formulation, has better kinetics. Now, for somebody who has to be given the drug through NG tube, and only tablet is available, you have to crush it, then we seek guidance from literature. We look at if any other people group has reported how to use that particular drug, in what dilution, what is the best way of diluting it or using that formulation. So like for posaconazole, although you cannot crush it, but there is a way of diluting it where you allow it to rest and then give it after 10 minutes, where you feel that there is a homogeneous distribution of the drug. So availability of formulations and calculation of dose impact pharmacokinetics, and very critical for children, pediatric population.
Yeah, thank you, Professor. I think because of the time, we have to end this very fruitful discussion. I mean, like, I can see that from our discussion that the issue of pediatrics safety is actually very complex, but at least we are lucky we have you both in the field that we need more study, I think, in this space. So, and also thank you for everyone who is posing the question. We hope that this discussion is valuable for you and you can bring more message, not just for your colleague, but also because I think in this Patient Safety Day, we aim to also increase awareness among patients, among caregivers, and also among our regulatory authorities. So we extend our thanks. Thank you to all speakers and all of you, and in making this World Patient Safety Day even possible, and focus on the theme safe care for every newborn and every child. We hope you continue sharing your experience and comments about ISoP 2025 patient safety on social media. And if you still have time, please join us for our upcoming presentation, which will come from the North America. So this is come from the Southern Hemisphere going to the North Hemisphere. And it will begin in a couple hours at UTC 1400 until 1600, or Eastern Standard Time from 10 to 12. And also don't forget to visit our ISoP online Facebook page or YouTube channel to view the recording of this webinar and other region webinars. And we will publish the records in the next few days. And of course, as a message, if you're not yet a member of ISoP, feel free to join us, because you will receive a lot of information, very useful information. Please join us this network, and we can exchange scientific and education innovations in pharmacovigilance to promote the safe use of medications. On behalf of ISoP, thank you so much for your participation and hope to see you in the next discussion. Thank you so much.
Thank you.